Good morning everyone. Welcome to another radiology case discussion. So today I'll be presenting about a 72-year-old gentleman who presented with left side back pain. So these are the T2 axial images. Here we are able to see the right femur cortex is thickened when compared to the left femoral cortex. And as we move cranially, there is quiescent trabecula which is seen in the right femoral neck. The left hemipelvis is also involved. Here we are able to see cortical thickening, which is better appreciated here, with evidence of quiescent, thickened, disorganized trabecula, which is appreciated here. The sacrum is also involved with evidence of cortical thickening and disorganized trabecula. The right hemipelvis is uninvolved in this section. As we move more cranially, there is a well-defined T2 hyperintense mass lesion just anterior to the left sacral ala. The sacrum is also expanded at this point. T1 axial images, again the same thing is visualized. There is coarsening of the trabecula involving the right femoral head. The right ischium and the left ischial tuberosities are involved. There is thickening of the cortex, disorganized bony trabecula, and the cranial section shows a well-defined T1 hypointense mass lesion just anterior to the left sacral ala involving the left iliopsoas muscles. Here we are able to see evidence of bone destruction, or the cortex is not clearly maintained when compared to the cortex which is seen here, as well as in the right sacral ala cortex which is noted here. The left sacral ala cortex is appearing irregular, and there is areas of bone destruction which is noted here. The next thing that we appreciate is the bone marrow. The bone marrow is fatty in the right sacral ala, whereas in the left sacral ala it is T1 hypointense in nature. Stir coronal confirms the same thing, that there is a mass lesion which is seen in the left hemipelvis anterior to the left sacral ala. The disorganized trabecula and cortical thickening is also appreciated in the stir coronal images in the left pelvis as well as in the right femur. Stir axial again confirms the same findings with the evidence of myositis which is seen involving the gluteus muscles. The CT correlation of this particular image shows that there is cortical thickening, trabeculae and bone expansion. The bone expansion is better appreciated here. We can compare it with the right side hemipelvis. There is definitely enlargement of the right hemipelvis as well as the sacrum, which is noted here. And the soft tissue mass which was seen in MRI shows few areas of irregular calcific foci or matrix which is favoring a bony matrix is noted. In the center of the mass lesion there is evidence of hyperdense calcification which is noted. The same thing which was noted in MRI is better appreciated. There is evidence of cortical destruction which is noted in the left sacral ala. Bone expansion is better appreciated here when compared to the opposite. Definitely there is bone expansion which is noted here. So to summarize the imaging findings, there is cortical thickening, quiescent trabecula and cortical expansion. This CCC findings is called as pathognomic triad of Paget's disease was present in this patient, which was involving multiple bones, the right femur, both pelvises, predominantly the left hemipelvis, the sacral ala. Apart from that, there was a soft tissue mass which was seen arising from the left sacral ala with infiltration of the left psoas and iliacus muscle. There was evidence of bone destruction which was noted in the left iliacus bone. So these imaging findings were suggestive of polyostotic variant of Paget's disease with malignant degeneration arising from the left sacral ala. So what are the diagnostic imaging features? So we'll discuss about few things alone, and because Paget's disease itself is a very vast topic to be discussed, so we'll restrict ourselves to 4 important things. One is what is the diagnostic imaging feature in Paget's disease, with the review of few imaging examples. Second thing was how to differentiate it from sclerotic metastasis. This is probably the most important thing that we will be facing in the day-to-day practice actually. Third thing is what are the complications in Paget's disease we need to look for when we are reporting. and when we are assessing a patient with Paget's disease. And finally, what are the malignant degenerations that can occur in Paget's disease? Coming to imaging feature in Paget's, depending upon the phase, we know that there are three phases. There is a lytic, there is a mixed, and there is a blastic phase. The lytic phase is predominantly characterized by osteolysis, and the blastic phase is predominantly manifested as sclerosis and bone expansion. The majority of the patients' Paget's disease will be presenting in the mixed phase, which has these four cardinal features. That is advancing osteolysis, which is the lytic component of it, and coarse trabecular, cortical thickening, and bone expansion, which are the blastic components of it. So these four imaging findings, that is osteolysis, cortical thickening, coarse trabecular, and cortical expansion or bone expansion, are considered to be the cardinal features of Paget's disease, out of which these three are considered to be the pathognomic triad. If any of these four imaging features are found in the imaging, then we can definitely and conclusively label that this patient has Paget's disease. Coming to the imaging features in Paget's disease, I'll just rush through some of the images of typical Paget's disease. So in the lytic phase, we see the osteoporosis circumscripta. That is, there is a well-defined radiolucent lesion which is seen in the skull. It predominantly involves the frontal or the occipital bone. There is no sclerosis, and there is an advancing osteolysis. It starts from here and keeps proceeding posteriorly. In CT, again, the same thing is seen. There is no evidence of sclerosis. There is a well-defined area of radiolucency which is seen in the right calvaria. When we move on to the lytic mixed phase or the blastic phase, there is cotton wool appearance. There is multiple areas of osteosclerosis which mimics the cotton wool appearance of the skull. Finally, that is the Tam O'Shanter's appearance. This is basically a hat in which there is overhanging edges. The cap overhangs and it covers the face actually. Same kind of thing appears here. This occurs primarily because of widening of the diploic spaces and platybasia, which leads to flattening of the skull base with the overhanging calvaria when compared to the facial bones. This is the typical hat appearance. Tam O'Shanter hat. As far as vertebra is concerned, there is the picture frame vertebra, which is basically the cortical expansion which is shown. The cortical expansion leads to sclerotic or lines which are seen in the superior, inferior, anterior and posterior margins, which leads to the typical picture frame kind of an appearance. The bone expansion, for example, in this patient there is a lytic sclerotic lesion which is seen involving the L5 vertebra, but if you see the posterior element, the spinous process definitely expanded when compared to the superior spinous process of L4 vertebra. So again, this is Paget's disease, not sclerotic metastasis. And anteroposterior diameter again is increased. The bone expansion is the most important feature in Paget's disease, which helps in differentiating it from other lytic sclerotic lesions. And when it is a predominantly blastic phase, we will be getting a typically sclerotic vertebra, which is called as the ivory vertebra. Ivory vertebra, when there is no bone expansion, then there are multiple DDs, right, from tuberculosis, lymphoma, sclerotic metastasis, Paget's disease. All these things will be differential for an solitary ivory vertebra. Pelvis, the obliteration of the Kohler's line. Kohler's line is formed because of the ilioischial line and the iliopectineal line. So when this gets obliterated and lost, that is typical of Paget's disease, which means that there is cortical thickening. When cortical thickening is present, the Kohler's teardrop gets obliterated. And there is a pelvic brim sign where the cortical thickening is seen in the iliopectineal line. The iliopectineal line here is narrow, thin, pencil-like, whereas in the opposite side it is thickened. So the same features are seen here. The right pelvis bone is pagetoid in nature. In long bones in Paget's disease, we are able to see that there is a blade of grass appearance. There is a leading edge which is more towards the center of the diaphysis, which typically starts in the subchondral or metadiaphyseal region and proceeds towards the center. Here again the blade of appearance, in which there is a blade which is going proximally. There is another wedge-shaped thing which is going distally. So it can be a unilateral or it can be a unidirectional or it can be a bidirectional blade of appearance. In more advanced stage, there is a typical cortical thickening, disorganized trabecula, bone expansion with a saber-shaped kind of a tibia, in which there is a bowing which can be either anterior or it can be lateral. Here we are able to see the ivory phalanx, just like the solitary ivory vertebra. Here there is diffuse sclerosis which is involving the proximal phalanx of the right second digit, and this is again a feature of Paget's disease. Here we are able to see insufficiency fractures or banana fractures, which is more horizontal in nature, which typically occurs in the convex part of the long bone, where more tensile strength is experienced by the bone. So this is another feature. This we will be describing in discussing complications of Paget's bone. So far what we saw was the important things that a typical postgraduate needs to know during our exams. It still keeps coming in spotters. But practically when we have a case, the most important thing that we have is the differentiation of Paget's from lytic sclerotic metastasis. As discussed earlier, if there is cortical thickening and if there is expansion, these are the two important things. Cortical thickening and expansion. If these two are present, definitely Paget's disease can be differentiated from sclerotic mets. These two images are that of Paget's disease. But here if we say this is a patient in which there is a sclerosis, there is no cortical thickening. If there is a bone expansion, then we can make it into Paget's disease. Otherwise, this becomes a very close differential for a sclerotic metastasis, which can either arise from the prostate or the breast. So whenever we have this kind of imaging appearance, it's always better to look for any primaries which are arising from prostate, breast, medulloblastomas, neuroendocrine tumors, or other tumors which can cause lytic sclerotic metastasis. Coming to the differentiating features, the disorganized cosine trabecula is a common finding between Paget's disease and lytic sclerotic metastasis. Both cause destruction of the trabecula, which can lead to disorganized trabecula, both in Paget's disease and lytic sclerotic metastasis. But the presence of cortical thickening and bone expansion are the two important things which helps us in differentiating it from lytic sclerotic mets. Third important thing is the medullary fat is preserved. Fortunately, majority of the patients, as in this patient also, we saw that the medullary fat is T1 hyperintense. Only in the place in which there is a secondary degeneration, we saw it was T1 hyperintense. So the medullary fat will be preserved and in case of Paget's disease, whereas it would be lost in case of lytic sclerotic metastasis. And coming to nuclear medicine findings, there would be intense well-demarcated uptake in Paget's disease, whereas there would be random amorphous patchy areas of uptake which are seen in metastasis. Anatomic detail will be maintained, whereas due to destruction it will be completely lost. There is a typical Mickey Mouse sign which is noted in the vertebra, in which there is two rounded opacities and the third opacity, third area of uptake which is seen here. So this corresponds to the two pedicles and the spinous process. So posterior elements are involved both in Paget's disease as well as in sclerotic metastasis, but the expansion leads to the typical Mickey Mouse sign which is seen in the nuclear medicine studies. FDG, usually there is no uptake in case of Paget's disease, whereas mets will have intense uptake. Coming to the complications of Paget's, there are four important complications which are described. One is arthritis. Due to extensive bone deposition, there is arthropathy which develops, which is secondary to the stress which is added onto the bone. Though there is added cortical thickening, all the bone which gets formed is all weakened bone. So there is a secondary osteoarthritis that develops. The most important thing about the arthritis which develops in Paget's disease when compared to the routine arthritis, osteoarthritis, there is no osteophytes. There is direct loss of joint space with sclerosis and cystic changes which are seen, but there is typically no osteophytes which are seen in the arthritis which develops in Paget's disease. Second thing, as we saw earlier, was the deformity and fractures. There will be multiple linear fractures which are seen in the lateral convex border of the bone, which are noted here, and sometimes it would be through and through fracture which would be seen actually. So this is again an MCQ: which part of the bone gets formed, the outer part or is it the inner part? Bisphosphonates fractures typically involve the inner aspect of the bone. Typically, in the third thing is the neurological entrapment. In skull also there is a typical MCQ. They usually ask whether the inner table is involved, outer table. Fibrous dysplasia, it is more of the inner table is spare, whereas in Paget's disease the inner table is involved actually. So when there is a diploic space widening, there is a narrowing which occurs in all the spinal foramina which occurs in the skull base, and there is platybasia, there is invagination, and which leads to neurological findings which are seen in Paget's disease. The fourth and most important thing is the malignant degeneration. Here we are able to see there is a pagetoid bone, but from here to here it is not a clear-cut fracture as we see here. There is a huge soft tissue mass lesion and there is an area of lysis. Whenever we see an area of lysis which is seen in a Paget's disease, then we should suspect malignant degeneration. Coming to malignant degeneration of Paget's disease, typically 1 to 5% of Paget's disease can undergo malignant degeneration, depending whether it is the monoostotic or polyostotic form. The various malignancies which occur in case of Paget's disease is osteosarcoma, malignant fibrous histiocytoma, chondrosarcoma, and GCT. The GCT which typically occurs in Paget's disease is usually benign in nature. Sometimes it can be malignant, but majority of the GCTs which occur are benign in nature. Apart from bone tumors, there can be also metastasis, lymphoma, plasma cell myeloma, which can occur in Paget's disease. Because the areas in which there is disorganization is the same areas in which there can be a hematogenous spread of these malignancies. So some patients might have a dual malignancy where Paget's with metastasis can also be present. How to identify it? When we see a cortical breach and a soft tissue mass, when we see these two features present in a patient with Paget's disease, then that is suggestive of malignant degeneration. Periostatus, usually most of these malignant tumors has various kinds of onion peeling, Codman triangle, but this is one particular malignancy in which the periostatus is infrequent. That is, the tumor doesn't give enough time for the bone to develop a periosteal reaction. Whereas in case of osteosarcoma, we see a Codman triangle in which the tumor is trying to form a periosteal reaction, but it is not allowed to form completely. So an irregular, partially completed periosteal reaction is seen. But this is such an aggressive tumor that there is no periosteal reaction that is noted at all. MRI has a very clear-cut role. In this patient also we can observe it. The right side sacral ala is showing a fatty marrow, whereas if we see the left sacral ala, it shows a T1 hypointense marrow, which is suggestive of malignancy. The bone marrow in case of Paget's is predominantly fatty. Sometimes it can be T1 hypointense when it is in the lytic stage or when there is a granulation tissue which is going on, but that would be patchy or speckled kind of an appearance. It won't be a diffuse infiltrative kind of appearance as seen in this particular patient. So here MRI scores over CT and identify whether there is infiltration of the bone marrow. So coming to the take-home message, so there are 4 cardinal features in Paget's disease, which is basically advancing osteolysis, cortical thickening, quiescent trabecula, bone expansion. Out of which the last 3, that is the triple C, cortical thickening, quiescent trabecula, and cortical expansion, are considered to be the pathognomic triad. Whenever we see a cases with Paget's disease, we need to check for any complications which have occurred, which are again 4 in nature, namely the arthropathy or arthritis, and deformities and fractures, and neurological entrapments, and very rarely malignant degeneration. The more practical the problem that we face in day-to-day practice is to differentiate it from sclerotic or lytic sclerotic metastasis, especially when it is a pure blastic phase of the Paget's disease, in which it becomes very difficult to differentiate from the sclerotic metastasis, and it can be done only by evidence of cortical thickening and bone expansion. If these 2 findings are present in that particular lesion, then it favors the Paget's disease. We also discuss the various malignancies which can occur in Paget's disease, and there is something called pseudosarcoma also, where there is increased bone formation which also leads to soft tissue mass, but usually there won't be any cortical breach which is noted. So all the soft tissue masses we have seen in Paget's disease needs to undergo a biopsy to rule out what kind of malignancy is present in the patient. These are the various articles referred for this particular presentation. This is a very good article in AHR which gives a concise approach, and this article which describes about the role of MRI and CT in Paget's disease. Here there is an article which tells us differential between Paget's and conditions in which there was a Paget's as well as a nauseous metastasis. Thank you. I thank the Madurai subchapter IRA. Last month, there was a meeting in which I was honored with the President Appreciation Award. Thank you, IRA, for the same. I thank our President, Dr. Pandian sir, and Dr. Kamal Subramanian sir, for the same. Thank you.